Welcome everybody to the breakout session addressing EMS need and identifying impactful activities. So all sessions are being recorded. If you are having technical difficulties, there is a blue help button at the lower right corner of the screen. You can click on that and then contact us for tech support. There is also a link to support@performmedia.com email on the login page for the reverse site visit portal. Lastly, you can click on the question mark button on the web player and that will redirect you to the help page. We encourage your questions and interaction with the presenters. For questions during the breakout session, you can type the question in the chat or unmute your line and verbally ask your question. To ask a question verbally, click on the icon labeled participants at the bottom center of your computer screen. At the bottom of the window on the right side of the screen, click the button labeled raise hand. The moderator will then call on you to ask your question, which you can do by unmuting your microphone. When you are finished speaking, please remember to mute your audio to avoid background noise. So just to reiterate a little bit, the learning objectives for this session, upon conclusion of this session, participants will be able to recall 2 state flex program examples of needs assessment, recognize ways to replicate similar methods in your flex program work, and describe how information gathered empowered clear decision-making for future activities. Excuse me. So with that said, our speakers today are Rebecca Dubert. As a program manager at the Oregon Office of Rural Health, Rebecca administers grant activities and provides technical assistance to rural health facilities for the Flex program and the SHIP program and all of the Office of Rural Health's EMS programs across funding streams. Rebecca is a former health policy legislative staffer and has experience working clinically as a certified nurse assistant and volunteering as an EMT in rural and frontier communities in 4 Western states. She has a BA in American history and holds certifications as a rural health clinic professional and sexual assault victim advocate. She serves on the advisory council of the Oregon Office of Disability and Health, volunteers for the Sexual Assault Resource Center in Washington County, Oregon, and has participated in fundraising and advocacy for type 1 diabetes for over 20 years. And then our other 2 speakers from South Dakota, Michelle Hoffman has 14 years experience in higher education, 8 years experience in the Wyoming Department of Health, Office of Rural Health, and most currently 2 years experience in the South Dakota Office of Rural Health. And then we have Marty Link presenting with Michelle. Marty serves as the Director of EMS and Trauma for the South Dakota State Department of Health's Office of Rural Health. Marty started his career in 2002 in state government and has served a variety of roles in addition to administering several multi-million-dollar grants over the past decade. Marty's primary focus is ensuring every South Dakotan has quality access to healthcare and building a sustainable workforce. So with that said, I did say that I wanted to go up and down the chat box and have each one of you just quickly unmute your lines. And all I want you to do is say your name and your state. A will know you got your microphone muted in case you have a question and want to chat. And then B will know where you're from. And yeah, so let's go ahead and do that. Let's start with Karen Pearson.
Hi, this is Karen Pearson, and I'm part of the Flex monitoring team with the University of Southern Maine.
Thank you, Karen. Alia.
Hi, I'm Alia Hayes. I'm with the New Hampshire State Office of Rural Health, and I'm sorry, I've already forgotten.
That's it, just basically your name and state.
Okay, there you go.
Yeah. Alyssa Kennett.
Hi, yeah, I'm Alyssa Kennett, and I manage the Wyoming Office of Rural Health.
Thank you. Carolyn?
Caroline Rosinski. I am with the Kansas Department of Health and Environment.
Thank you. Excuse me, Dawn Waldrop.
Hello, everyone. I'm Dawn Waldrop with the State Office of Rural Health in Georgia. Thank you.
Thank you. My list is moving around. Gary.
Hi, Gary Wingrove. I'm with TASK.
And has sort of been with TASK for longer than me, and that's a long time now. Thank you, Gary. Michelle.
I'm Michelle from the South Dakota Department of Health.
Thank you. John Noakes.
John Noakes, Washington State Department of Health.
Thank you. Caitlin?
Caitlin Thomas, South Dakota.
Thank you. Lima?
Hi, I'm Lima Chagorian from Nevada.
Thank you. Laura?
Laura
Grandin.
Fisher from Illinois.
Oh, that'll work too.
Sorry.
No, that's all right. Laura Grangard Johnson.
Hi, this is Laura. I'm with Stratus Health in Arcata in Minnesota.
Thank you. Marty?
Hey, Marty Link, South Dakota.
Thank you. I lost my place. Marty Link. Renee Clark.
Hi, I'm Renee Clark. I'm from the Office of Rural Health in North Carolina.
Thank you. Rebecca?
Rebecca Dobert, Oregon Office of Rural Health.
It's kind of a surprise, right? You guys have to be paying attention. You can't just know my name's coming up eventually. Sarah Anderson?
Hi, Sarah Anderson from the Oregon Office of Rural Health.
Thank you. Britton? Britton is unmuted, but I don't hear anything. Okay. R. Kirby?
Yes, I'm here.
Could you just tell us your first and last name and what state you're from?
Ruby Kirby, and I'm from Bolivar, Tennessee.
Oh, that's right. You're on our task advisory committee, and you're a hospital administrator, right? Okay, thank you. Becky Royer. Looks like she's connecting. I'm not sure if she's having an issue or not. Did I miss anybody? Clarissa.
Hi, everyone. This is Clarissa Noble, and I'm from the Virginia State Office of Rural Health.
Thank you. I see Britton typed in the chat, Britton Herbert from the South Carolina Office of Rural Health. Thank you. Okay, we are going to go ahead and get started. It looked like South Dakota was going to start. So you can go ahead and share your presentation again.
Okay, this is Michelle. Hi, Flex program colleagues and friends. I sure miss seeing you in person, but we'll see each other next year. And thanks for joining this session, Assessing EMS Need and Identifying Impactful Activities. I'm joined by Marty Link, the Director of EMS and Trauma. The South Dakota Office of Rural Health is fortunate to have both SOAR grant functions along with EMS and Trauma. Not all states' offices have this luxury. In some states, EMS and Trauma may be in the same division, but not in the same office. This camaraderie and cohesiveness of our office speaks for the South Dakota Office of Rural Health. The relationship we have is partly due to the small state and population and the dedication we have to support our rural communities. The cohesiveness allows for some unique partnerships in which to serve the rural health communities in South Dakota. This brings us to the activity today, the EMS Needs Assessment for the presentation. Marty was the director of this activity, so I'll now turn it over to him.
All right, thanks, Michelle. So before we begin, this little glow here wasn't planned. It's just God's little joke with my forehead being and my head being bald there. So what we wanted to do, we've been working with emergency medical services across the state of South Dakota for a number of years. And we've always focused on the ambulance services themselves and the ambulance service directors. It's the primary point of contact for all of these services and most applicable to have discussions with them. But as we started to dive more and more into this knowledge base, we realized that the ambulance service directors just had it gave us one facet of the challenges that they're having at a local level. So this project is really a key component to what we call an overarching vision, and we'll share a little bit about the vision of EMS that we have moving forward and what we call the vision of EMS in 2040. So as we started to work with service directors, we worked with Safe Tech Solutions, And we held a number of what we called leadership classes, and we brought all these EMS directors in, and they started to share with us some of the challenges that they were having, challenges with funding, challenges with community support, city and county official support, how to really operate that business at a local level, because many of these folks were volunteers. And they also talked about the challenges that they're having with some of the subsidies or lack of subsidies. We thought, holy cow, we've got a great knowledge base with the EMS directors, but we're really missing out on a key component when it comes to the policymakers and those that are funding these ambulance services at a local level. So we'll get in here, but before we start, we've got to begin with the end in mind. So when we look at our vision, South Dakota has a great EMS system, but we want to make it better. We have a lot of opportunities for improving this. So when you look at our vision, simply states in 2040, EMS in South Dakota is a system of care in which all South Dakota residents and visitors have reasonable and reliable access to quality mobile healthcare resources. The system is going to be dynamic, a dynamic creation, and the result of ongoing reflection, planning, evaluation, and improvement. And that's what we find is EMS changes and healthcare changes so quickly and so rapidly, we have to be able to evolve with it. So some of the guiding principles we have this, it has to be people and patient-centric. That's got to be the core of this vision. It's got to be practical. We've got to be able to do it, and we've got to be able to inspire fruition. And really this inspiring ambulance services, community leaders, elected officials is really challenging, and it takes a consistent voice over and over, almost like a broken record, I say sometimes to the staff, but it's really sharing that positive message of where we are and where we need to be in those steps, that the gap analysis between the two. It's got to be socially and financially equitable. And certainly when we talk about safety, it's got to be safe for our providers, it's got to be safe for our patients, and it's got to be safe for the public. And, what not a better time to really look at that with all the COVID and what's happening there. We have EMS providers really fearful of going home and exposing someone who has comorbidities at home with what they might have seen on the road. So we're really very sensitive to the volunteer nature that we have of EMS providers in South Dakota. And it also has to be locally and historically sensitive. And I'm very much so sensitive when it comes to this. There are a lot of folks that gave their blood, sweat, and tears, and they're what we call pillars of the community. They've developed that ambulance service at a local level. We want to make sure that that legacy stays with them and remains intact, while also being able to move forward, because some things just simply aren't, some things just simply need to change at a local level. So when you look at our vision for the future, we've got some key elements to that. It's got to be valued, it's got to be recognized, and not only locally, but it's got to be supported by community members, local healthcare. It's got to be a true system of care. Even today, we see some fragmentation, if you will, between EMS and hospitals and other healthcare professions, and we need to shore up those gaps. We've been doing an incredible job, but it takes a daily effort to be able to have that cohesive team put together and have everybody trust each other in a manner they need to be trusted in. It's got to be sustainable. Obviously, we need to have a competent workforce. We need to know our skills, the depth and breadth of knowledge that we have to do those skills, and we've got to be adaptable to changes into the industry and things that are moving into the future. So how do we do this? So the main thing we need to do is we need to continue to build upon our past work, and that includes our successes, and it also includes our failures, what we've done wrong, what we've discovered along the way. And we've learned a lot through the process. We need to continue to educate EMS groups, associations, communities, but especially elected officials. They really need to be educated on the intricacies of EMS at a local level. And some are very open and receptive to that, and others, look at it as, boy, this is a lot more than I had bargained for. I mean, there's a lot of information here and a lot of good knowledge, but it's kind of scary sometimes when you really start to talk about where EMS is, and knowing that the volunteer model is simply going away in the near distant future. We've got to expect ambulance service closures, and that's something I hope everybody on the call realizes. It's certainly not something that we don't ever want to think is going to happen, but even in South Dakota, we had an ambulance close very abruptly, and it is really, even to this day, taken some challenges to make sure that we have coverage area, to make sure that dispatch knows where, which ambulance to send to which geographical area that they can coverage area now. So it develops some challenges there. So I would encourage you, if you haven't already, build those plans, foresee that because it will happen. So the community leader, really the meat and potatoes of this, is we looked at the demographic and we targeted city and county elected officials. We looked at hospital CEOs. We sent out mailings to business leaders and said, we want you to respond to this survey. We want to gather as much information and really discover what perceptions were out there about EMS. We wanted to gain an understanding of their real, what was the reality as far as the mindsets of elected officials and how they saw EMS at a local level. And then once we had that, we could establish a baseline, and that would be a baseline for us to educate these folks moving forward. When you look at the expected end, we really wanted to prepare leaders for the reality of what's coming. And that reality is that volunteerism is going away. And we need to be prepared for that so we don't have that jerk reality of, oh my gosh, our ambulance service just closed. Now we need to start some planning because you're behind the 8 ball from the moment that happens. So town hall meetings, we followed the survey up and we did 8 town hall meetings across the state of South Dakota, kind of a road trip. And they're very educational. We learned a lot from community leaders. We had folks that were very open and receptive to listening to the results of the survey. And it was a good experience for us just to be able to, again, capture the knowledge base and what the community felt of their local EMS agencies. So we talked about the vision, and we talked about where we want to go, but we need to talk about where we are now. And I'm going to go over these slides fairly quickly. In South Dakota, 95% of our agencies utilize volunteer labor. Only 35 of them are all paid staff. So a large majority of our services are volunteer. Active roster members, when we look at this, our average age of EMS providers is 49 years of age. When you look at the chart, you see 62 of our agencies have 10 or less active members on the roster. So what's the relevance of this? You think, well, 10 sounds okay, but when we do the research, and a lot of this comes from Safe Tech Solutions, our partnership with them. When we do research, we said we need 14 active members of an ambulance service in order to have a safe and humane ambulance. That means 2 people are on call 24 hours, and that's it for the week. And then they can go on their daily lives. They can work their regular job, but for that 24-hour period, they're on call. If you were to call some of our services around the state, they would laugh at you and say, that doesn't happen. I'm on call for weeks at a time, months at a time. Sometimes I go, literally years at a time without leaving their community. They're constantly on call. And that's not safe and humane. That's not where we want EMS to be. We want EMS to grow. We want it to be enjoyable. You look at the stresses that these folks go under on a daily basis. We want to make sure that we can have safe and humane staffing and make sure that we do the job that needs to be done by protecting them. Population served, this is important. So research again says you need, for every 100 people, you may be able to get 1 volunteer. When you look at the slide, we have 46 agencies that serve a population less than 1,000. That calculates obviously out to maybe 10 members, which is below that threshold of that 14 active members. So it really challenges the recruitment and retention processes in these smaller communities. So some of these that have ambulance services are only 250, 300 community members. This slide, I want you to look at the annual call volume. 95% of our agencies have a call volume less than 500 calls per year. So what's the significance of this when you look at this slide? Research, again, with Safe Tech Solutions talks about that you need at least 650 calls annually to be able to support 1 ambulance, 2 crew members, 1 ambulance, 24 hours a day, 7 days a week. So by this being under that threshold, immediately that tells you that you need volunteer subsidies in order to have your service stay out of the red. I mean, there's just no question about it. But the bigger point there is, as we move from this transition from purely volunteerism to more of a paid structure, we realize that not every ambulance service is going to survive. We have one county that has 5 ambulance services. Each of those services are struggling, And it wouldn't be fiscally responsible to shell out $500,000 for each of those services to be able to sustain. It just wouldn't be, appropriate. So the challenge comes with leadership is convincing them and working with local community leaders, working with elected officials to say, where we are right now isn't working. We need to change the processes, and we need to change how we provide healthcare. And that means some of your services may close, and some of them may have to dissolve. You can still have the community pride. You can still engage in your community as an EMT, but you may not have a service, an active service with an ambulance going up and down the streets. And that is the reality today. So it's having those discussions with these local leaders to share with them, this is where we foresee EMS going. We need to make some changes. This slide wasn't alarming to us. We had 32% of our agencies say, yeah, based on the facts that we just saw in previous slides, 32% we've missed calls in the last year. 29% we've had delayed calls. And these aren't nursing home transfers. These are cardiac arrests. These are major traumas. That really shows that those time-sensitive emergencies, we need ambulance services that have a shoot time very, very quickly. That page goes out there en route in a few seconds to a few minutes. So there's some disparities in reality when we look at some of our smaller agencies and where we can improve upon. So we talk about decline in volunteerism, and I think these bullet points are not going to be shocking to anybody. We've got economic changes, the social community changes, the generational change just in general. The younger kids are more selective on where they want to volunteer. They want to volunteer at a church for 2 hours on a Sunday morning because it's predictable. But carrying around a pager and not knowing when that thing's going to go off and when they're going to have to leave their family, their friends, is a challenge. You look at demands on work and the demands of work. Many of our families, both parents are out working now just to make a living, just to have a roof over their heads. Where in years past, it might have been one of the parents out working. And when we look at regionalization of healthcare, this is a huge impact, where we see more and more of our ambulance services going over the road on long interfacility transfers to get to some of those parent hospitals. So there's some of the challenges that we have. So this is sticker shock, right? So we talk about educating city and county officials. We say, look, at the end of the day, if you did have to subsidize your local service, this is what it's going to cost, $450,000. And again, part of this education is looking and saying, okay, does that local service really need to exist? If you have 5 ambulance services in one community, really a stone's throw away, do you need to support each one of those, or could you liquidate some of the assets, form 1 or 2 solid ambulance services that are full-time that could respond in a moment's notice? And really painting that picture for them so that they can work through those challenges and look at, yeah, there is a better way. We need to start having these conversations. So very quickly, when you look at here, some of the points, we need to really start having that, continue to have that conversation at a local level with community members. We have 97% say EMS is an essential service. Absolutely. We've got 63% that do not view the current staffing model as sustainable. That's a problem. But why are we not having those conversations at a local level? And again, that takes leadership from above to really step into some of these communities and have some of those tough conversations, because they're scared to have them at a local level. That brings fear because it costs money at the end of the day. But there's a lot of good points that came out of the survey. So what we did, so the fruit of all this labor is we developed a book, Safe Tech Solutions Help, developed a book on what everybody needs to know about EMS in a rural community. And this has been shared far and wide with legislators, our House folks from the representatives, city and county officials. Far and wide, we cast this net. And then we also did what we call a micro assessment, where we looked at one county and we did a detailed evaluation of every one of those ambulance services, the 5 I talked about, to really pave a way for those local leaders to be able to make decisions on how do we effectively have a robust ambulance service at a local level and be able to manage that instead of 5 services that are really struggling. So in a nutshell, that's where we're at. Next steps, we were going to continue our work on the EMS vision for 2040. A lot of education and a lot of work with elected officials. But that's all I have for the presentation.
Great. Thanks, Marty. Did anybody have questions for Marty or Michelle?
John Noakes, Washington State Department of Health here, Marty.
Yeah.
So, we're working with Aaron as well within our state and some of our project stuff. And I was going to reach out to him here shortly, but he talked about the models, and one of the things he's talked about also is, the community being aware of what ALS versus BLS versus the cost of services and all those kind of things. Are you aware of anyone that's actually, it looks like you guys put out a good model to send out paper documents to folks. Has anybody done any kind of video stuff that says, hey, I'm an EMT and here's the kind of training it takes and here's what I can do versus an AMT? Are you aware of anything like that?
No, not in the state. I mean, our ambulance association does a great job of marketing that, but as far as marketing to the general public, there isn't any campaigns like that have been taking place.
Just curious because again, Aaron has kind of talked about when you're trying to sell this stuff to the community, they really need to understand what they're getting for what value. Thank you.
Absolutely. Yep.
John, I think Wyoming is doing some work related to talking to the community and kind of educating them about the value of EMS. I'm not exactly sure what they're doing, how they're doing it, if it involves videos with the angle that you're talking about, but you could definitely get in touch with Kyle Cameron. And if you send me an email, and I will put you in touch with Kyle and you can find out what they're working on.
Okay. Yeah, I was going to touch base with Aaron, but already was talking
I feel
about
bad for that. Dang.
Nope.
Oh, hi, Kenya.
Hello.
It's Nicole at Task, and you are unmuted, just to let you know.
Oh, hello.
All right.
Sorry about that.
That's all right. Any other questions for our folks from South Dakota? All right, we'll go ahead and turn it over to Rebecca Dubert then from Oregon. Rebecca, you can share your screen.
Hey, Nicole, this is Jill. How do we get a copy of that publication, or how do we see it?
Maybe Marty could put a link in the chat, or Michelle.
Okay, thank you.
Okay, yeah.
Yep.
If I don't see it pop up, I'll track it down.
Sounds good. Yep, we'll get it to you.
All right, thanks.
Okay, I'm going to jump right in if we're good to go.
Yep.
Hi, everyone. Thanks for joining me to hear about the Oregon project, Rural and Frontier EMS Listening Tour. We have a lot to cover. I'm going to talk to you a little bit about what we heard and how we implemented the project, and I hope that you enjoy. We have a little bit of a photographic representation of what we got to see during our listening tour. So keep that in mind as we're going. All these locations are where our EMS folks are working in Rural and Frontier. So starting off, I am trying to advance my slides, but they're not going. There we go. Thanks. I work at the Oregon Office of Rural Health. We are a university-housed organization. We are divided into 3 teams: administrative, workforce, and field services. I'm a program manager with the field services team, and we have a focus on providing data and funding support to the rural health clinics, critical access hospitals, and increasingly rural and frontier EMS. A few notes about rural in Oregon, which will be pretty familiar to folks in other Western states, but I like to throw out some of this stuff for scale and overview for folks. Our rural definition is any geographic area in Oregon 10 or more miles from the center rate of a population of 40,000 people or more. Frontier counties are defined as those with 6 or fewer per square mile. Oregon has 10 out of our 36 counties that are frontier designated. I like to note that while 1/3 of Oregon's population lives in rural or frontier, 69 to 70%, depending on how many are licensed in any given year, 69% of our ambulances, their ASAs, their ambulance service areas, serviced rural or frontier, either exclusively or in part. For our listening tour, the participant counties included more than half of Oregon's 98,000 square miles. So that's larger than the entire state of Pennsylvania, Oregon itself is actually bigger than the United Kingdom. And also of note, the high points of the listening tour averaged about 4,900 feet higher than the highest point in Pennsylvania. I referenced that, I'm a East Coast grown person. But anyway, I mentioned that to think about the terrain. Terrain and scale are really important for us here in rural and frontier Oregon, because if you're not scaling up or down from a mountain range, you're bordered by the Pacific Ocean. So our EMS faces a lot of distinct weather and terrain challenges when they're serving. This is a nice visual of the rural and frontier areas in Oregon. You can see mostly our eastern counties are in the dark green. Those are our frontier counties. Light green are rural designated areas. But it also shows the scale of the counties. Harney County, for example, is over 10,000 square miles and is one single ambulance service area. So, and our rural and frontier EMS folks work mutually not just with their Oregon agencies, but we have borders with California, Idaho, Nevada, and Washington for folks to work with. So, building the listening tour. So, what is a listening tour? I'm coming at this from a little bit of a different starting point than South Dakota. Our project was coming in, as I mentioned, our EMS work at the Office of Rural Health has been increasing in Oregon in recent years, primarily under the FLEX grant, sometimes under SOAR and other funding. But as we've been able to expand into the optional program areas and activities under FLEX, we've added EMS. So we were really at a starting point of a resource organization that engaged with EMS, but we didn't have a ton of programming already in place. So our listening tour model was something that we conceived to provide a type of a living survey or needs assessment. Really a way to engage in real time on site with our providers and hear their assessment. And also a way to break down some of the barriers between us as a resource organization and the agencies and really demonstrate our commitment to hearing from them directly and then accurately representing their voice in programming and advocacy. We first used the listening tour model in 2014 to engage with critical access hospitals. Later, we expanded it to include RHCs and other rural, and have been going with that forward. So building a listening tour, we started with funding. We applied for and received a Medicare Rural Flexibility Grant, a Flex Grant EMS supplement for the fiscal year 2018 period. And we were proposing to use our listening tour model to focus on the objective of developing and implementing sustainable models. So again, that format is on-site, in-person meetings only. We do not allow call-ins or representation. That's an important part of building these tours. And then we coordinate and schedule the site visits and the meetings. Another important part of building our EMS listening tour was we were able to increase our reach by partnering with the Oregon Health Authority, EMS and trauma systems. That is our Oregon EMS regulatory body. And that afforded us a couple of things. Aligning our work with them enabled us to access their data sets. They have licensure data that they capture with the annual licensure renewals for transporting agencies, access to the Oregon MSIS system, their historic EMS projects, and their work with our county ambulance service area plans and programs. So it was really nice for us to be able to tap into that data and analysis. And then also we were able to luckily work with someone who was working part-time on their project, who was a subject matter expert, and I'm speaking for her here. She was a wonderful catch. She's been an EMS provider, paramedic in Oregon since 1978. And she really came in with some long-standing connections and relationships and helped get us in the door, quite frankly, where we hadn't established our relationships. And that was a wonderful benefit. So it was a nice overlap that's continued. Right out of the gate, the alignment with health authority folks enabled us to update some resources that were available to everybody, not just us. This is the ambulance service area plan for Oregon, which was badly out of date when we were setting off on our listening tour. So we were able to update that. And it nicely shows now all of the ambulance service areas. You can see some counties are a single ambulance service area and some have up to a dozen. So our folks are really working within a wide framework. So that was a nice resource right out of the gate that we were able to improve with our collaboration with the Health Authority. So building listening tour, our site selection was really important to us. We wanted to be thoughtful and make it meaningful. And we wanted to meet not just with folks who had challenges to identify, but also folks who were experiencing success and hear from them why they thought that was. And this model is based on us going out to folks, not sitting in Portland and saying, well, we think what we're hearing is this, and we're going to target resources. We worked with the Health Authority to develop a scoring system based on those licensure surveys that we were able to access. Basically it was a, green, yellow, orange, red. Low scoring agencies being deep in the red were considered operationally unstable. Green and yellow, operationally stable. And in fact, right after the scoring system was set up and weighted, one of the red scoring agencies folded. So we had some early indications that the scoring was on the right track. So let's see. Then we set up our tour. Our tour covered all areas of the state. This is a map of where we held the meetings. Ultimately, we had 10 meetings in 10 counties. We hit 5 frontier counties and 5 rural designated counties. And we really got nice representation around the state. We had really great participation. And after we held all of the meetings, it was then our job to kind of take what we heard and compile it into a summary report and then start some of our work in earnest. The results and the report. What did we find? Well, initially, we found that a lot of folks wanted to participate. We had 36 stakeholder and partner agencies participate. That included 1 non-transporting agency, but we had fire response agencies, public health, law enforcement, county public health and emergency preparedness, critical access and rural hospitals, and we had hospital-based EMS agencies, folks in health districts, and also independent, primarily volunteer agencies. In total, we had about 20% of the licensed transporting EMS agencies participate in meetings and in the listening tour, which was really fantastic. We were very excited. So what we heard, nothing that is unfamiliar to anyone, but again, it was a really nice chance for us to have the Oregon specific perspective and have it validated and verified from the providers' mouths. First and foremost, the top reported challenges were around personnel, recruitment, education, and training. 100% of our agencies reported that some aspect of recruitment and retention was a top challenge. We heard a lot about the training and licensure program locations, the availability barriers. In fact, 2 of the tour counties fell completely outside of EMS community college education catchments. 7 of the 10 tour counties did not have paramedic level training. So even if folks wanted to pursue it, it was not available within their county. A lot of talk about the cost of licensure. The cost being tuition and exam fees doesn't even take into account the travel for rural and frontier students, which was often prohibitive, especially if you have to leave your county several times a week for that training. Discussion specifically of a lack of rolling admission cycles so that students were bound to what worked for the programs and not for their lives. And our average cost at the time for tuition and fees was about $2,000. And frankly, that brings us to our next thing. That's the base cost to support a BLS licensure to staff a service without including travel costs, time away from home, to be an uncompensated volunteer, most likely. Which is our next personnel challenge. A lot of folks talking about volunteerism not being a sustainable model for them. They have lots of folks who are interested, but they simply can't volunteer. The folks in our counties, our rural and frontier counties, like everywhere else, skewed older. Meaning less volunteers available overall and increasing level of retirement for the volunteers who were in place. Our tour counties averaged about 30+% Medicare eligible. The economic barriers are increasingly real for everyone, including rural and frontier. The unemployment rates in our tour counties ran between 4 and 10%, and this is pre-pandemic. So they all had an average per capita income below national average. So the economic barriers are real, and quite frankly, you know, rural and frontier faces the same additional economic barriers as urban. Housing availability, scarcity pricing, increasing costs of living for food, fuel. These are all very real in rural and frontier places as well. And on top of all of that, you're most likely going to end up volunteering. And on top of that, you're going to be asked to do other skilled work, such as billing and equipment and vehicle maintenance. And a lot of times they toss in some grant writing and other skilled projects just for fun. So the other top reported challenge was billing and reimbursement, of course. And most of the folks called this out based on a lack of dedicated billing staff. It was definitely, billing and reimbursement are complicated. Folks specifically pointed out Medicare and Medicaid billing processes can be very complex and also require additional time on task for collection of that payment. And when you do get payment, reimbursement doesn't always cover the actual expenses. 80% of our agencies reported this as a top challenge to their stability. And about half, 47% of the agencies estimated their payment collection rates at 50% or less, primarily due to the limitations of billing staff. And in terms of not covering costs, for us, the folks really faced a lot of extreme geography and transport expenses, ranging from vehicle maintenance, update, and then fuel costs fluctuating all over the place. We also found that there was a wide variety of billing rates, non-standard billing rates for both services and mileage. For ALS and BLS rates, there was a $1,900 difference between the lowest rates being charged and the maximum rates being charged. And for mileage rates, the highest rates were more than 6 times what the lowest rates were. So there was not a lot of understanding across agencies about how to maximize their billing, quite frankly. Almost everybody everywhere said this. They're self-sufficient and they're happy to be, but they can't manage it all. They have an increasing burden, as I mentioned, to add other skilled, outside of being licensed skilled medical providers, they're also being asked to be grant writers and billing experts and put in a lot of time on task for very skilled work. A few things came up that were not necessarily universal, but they were mentioned enough and specific enough to rural that we wanted to make sure we communicated them to folks who don't operate in rural and frontier environments all the time. Very often folks wanted to remind us that the communication systems in rural and frontier are not always standard. Everybody knows the place on the road, on your calls out or your way back where you can pull over and where you're about to lose service or where you're going to get service again, no matter what kind of communication system you're working with. The extra vehicle wear and tear, which really was extreme and a serious consideration in our frontier places. We have, you know, Lake and Malheur County are over 8,000 and 9,000 square miles on their own. They're hitting 100,000 miles within a matter of months just for routine transports. It's a significant budget issue for them, for vehicles and for fuel. And one that came up originally mostly in Southwest and Southern Oregon as communities there used reduced law enforcement to make up for budget shortfalls. But in the last year, 18 months, we've heard a lot more across the board, but folks were very aware of the reduced funding of law enforcement. We have several communities who don't have 24-hour coverage, but folks know when they call 911 that someone in a uniform will respond, whether they're the appropriate someone or not. And our EMS providers were very aware and concerned about being the first uniformed folks on scene, often inappropriately. So we made sure to point that out. As I mentioned, we tried to include folks who were experiencing instability, but also folks experiencing stability, because we wanted to hear in Oregon what is working. So our green and yellow scoring agencies had some commonalities. They were all hospital-based and or located in a special health tax district, so they had funding support. Their personnel almost universally reported all of the following. They had at least some full-time paid staff, and that includes medical directors. Medical directors are often volunteer here for EMS services. The ability to offer a stipend or some payment to the folks who were volunteering. And then everybody called out support for billing and payment collection from hospital or paid staff. The folks in the tax districts also really often and strongly spoke of the community buy-in. They felt like their community members had actively supported them, voted for it, and they heard it and felt it in their responses. And that was a really nice side benefit that we frankly didn't expect to hear. And they all universally accredited these things. They said, this is why we're stable. We just have more resources and we have more support. So the listening tour, these meetings, these models, not only are they great and they get you on site, they generate both immediate and long-term action items. And I always found that the immediate action items, although they were often unanticipated by us, they offered a real opportunity to get right to work and demonstrate our commitment to putting in place some resources to help with solutions. And then our long-term action items are that opportunity again to accurately represent the voices from the field and then target our resources. We finished and published the report, disseminated it to all the usual suspects, the state and federal legislators, policymakers, and our partner orgs. In the end, not only, so the dissemination of the report, the amplification of the voices, and the relationships we built on the road with them really helped the Office of Rural Health increase our collaboration and establish us as a resource organization to be included in the EMS conversation. So we really have just come out on fire. I'm very excited to participate with NASEMSO, our NAEMSP chapters, our Oregon EMS Association, the Medical Board EMS Advisory Council, our Ambulance Association, our State EMS Committee are all very actively engaged with us now. And we have a lot of great just cross-organizational pollination happening. We're at the table and they think of us as a resource org, and now the agencies also think of us that way, which is wonderful. The continued partnership with our health authority, our subject matter expert who helped get us those meetings in the door has now been hired full-time to administer the EMS program in Oregon, which is wonderful. And they have really refocused their rural and frontier work. In fact, they rolled out 2 rural focus equipment and tech programs, grant programs in the last 2 months, which is wonderful. We were able to recruit EMS personnel to our Rural Health Association board and then include him in our Hill visits for the Policy Institute in February, and he brought a fantastic EMS perspective and voice to our visits. So really a lot of good ongoing work and collaboration that has come from this. One quick note, our final happy ending, we were also out of this listening tour because we came in under budget in a few areas and had some matching funds. We were able to make some immediate mini grants to support sustainable programming in a lot of the participant agencies. Most of them were education related, and most notably Wheeler County, one of our counties was, during the tour, they came to us and said, we're losing all of our EMS coverage in a third of the county. And I'm happy to note we were able to support, help support a cohort of folks, and 18 people graduated in April, and all of them are volunteering and working in the county, including the ASA that was entirely without EMS support. So onward and upward. I hope that this has helped demonstrate the value of an on-site assessment model such as a listening tour, and how it can help build and strengthen your communications so that you can target your resources accurately and appropriately based on real-time assessment from the field in your state. And hopefully you'll be able to get out and see some of your beautiful country the way we have been able to, and engage with folks. And that is me.
Thank you, Rebecca. We are at 1:15, so we're actually 5 minutes over, so we don't really have a lot of time for questions. I would suggest if you have any questions for Rebecca, you can find her email address on the State Flex profiles on our website, or you can reach out to me and I will put you in contact with Rebecca so you can talk more with her about their EMS listening session. Thank you everybody for sharing your information. It was fantastic. So as I noted, we are at the end of our session and we're going to have a 5-minute break now. We'll reconvene at 1:20 Central Time for a facilitated discussion on managing the state flex program during COVID-19. At the conclusion of the breakout session, a clickable link to the discussions will be made available on the screen. If at any time you have to step away or lose connection, please note that you can always return to the portal to access the live sessions at any time. So we'll see you guys in 5 minutes for the next session. Thank you.